Okay, we're going to talk about immunotherapy for melanoma. Let's see if we can, and just to give you a little perspective about immunology, immunotherapy, and melanoma, 30 years ago when I was a graduate student, I asked my thesis advisor if I could take a course on how the immunologic system related to cancer. And he said, why would you want to do that? It's going to be a total waste of your time. So I, as always, ignored his advice and went to a place called Cold Spring Harbor, which is out in Long Island, and learned a lot. And at the end of it, I said, I think he was right. I don't see a future for immunology here. Well, as always, I was totally wrong, and eventually came around to the fact that the immune system plays an extraordinarily important role in cancer, and melanoma has kind of led the way. And again, what's the problem? Well, once melanoma spreads, it's bad. And there was a guy named George Canellos who is still alive. He was the physician-in-chief at Dana-Farber in Boston, and he's known for saying melanoma is the tumor that gives cancer a bad name. And I sat next to him at a dinner once, and he said, yes, indeed, he said that, and he has said that for 30 years. And it used to be quite true. But what about the immune system? And can the immune system tackle melanoma? Well, why do we have an immune system? Okay? It evolved pretty much to protect us against infection. It did not evolve to protect us against cancer. There are different mechanisms. We have an innate immune system, which is kind of the preset built-in immune system, and we have an adaptive immune system. What does the word adaptive mean? It means can change with circumstances. And in the immune system, it's this extraordinarily complex ecosystem. You have chemicals that work within the immune system, like antibodies, it's a chemical, and you have cells. And again, the first line of defense is the innate immune system. It pre-exists, it's primed, it's ready to respond to infection, inflammation. And an example would be macrophages and neutrophils. Those are cells that are in our circulation, and they help protect us pretty much against infection. It's not what I would call educated. It's kind of not even very selective. It sort of kills first and asks questions later. But it's an important part of our protection against infection. Adaptive immunity is the other side of the coin. They are mostly cells. There are B cells that make antibodies that protect us against a lot of things. And there are T cells which act as the killers and the helpers. They're educated in the sense that those cells actually can learn, which is what the word adapt means. They have memory. Just as an example, I was vaccinated 37 years ago against hepatitis, and I still have both antibodies and immune cells directed against hepatitis B in my circulation, which is pretty amazing. I mean, 37 years later, I'm still protected. So that means the immune system is incredibly powerful. The adaptive cells, the B cells and the T cells, are very specific. They are selective. So my protection against hepatitis B that's 37 years old doesn't protect me against hepatitis C. Useless. Or hepatitis A. It's only directed against hepatitis B. Protecting against cancer is another scenario completely, because the problem with cancer is the cells are derived from your normal cells. In fact, if you look at the genetic changes, there aren't that many changes between a normal cell and a melanoma cell, for example. They quickly evolve to lose the expression of the things that could distinguish them from the normal cells by the immune system. And they're very nasty. Melanoma cells in particular produce all kinds of wacky substances that actually suppress the immune system. So think about how diabolical that is. And then the sicker you get with melanoma, the more metastatic melanoma cells in your body, it becomes much more difficult to deal with the immune system. And if you get chemotherapy, for example, which many cancer patients do, although not so much in melanoma anymore, you can't really mount a very good immune response. So what's the problem? Well, we want to exploit the immune system to fight cancer, and the problem is it never evolved in that way, right? Think about it. Humans, until, I don't know, a couple of thousand years ago, had a lifespan of about 40 years. Cancer isn't a problem up to the age of 40 in general. Pediatric cancers, thank God, are relatively rare. So cancer only became a problem for us in the context of a long life, which has only occurred, I don't know, over the last couple of thousand years of human existence. So it evolved to do a great job of getting rid of infection, but it doesn't do that great a job of getting rid of cancer, which means we need to help it along. And what are these immune cells? Well, most immune cells act in the sense of infection. So let's say you had a a bacteria or a virus-infected cell here, it would carry, so you would have this innate cell, this macrophage. It carries along the virus or the bacteria within it, and it presents it to the immune system. It shows it. So you have different types of immune cells. You have memory cells, helper cells, and as soon as they recognize on that macrophage or on that cell that shows them the foreign invader, as soon as they recognize that it's there, they're going to start dividing. You're going to get lots of them. They're going to multiply like crazy. They're going to go hunt out the infected cells and get rid of them. So when you get a flu infection, you have this huge immune response. You get lots of T cells. They go to your lungs. They get rid of the flu, and you feel crappy for about a week or so because they make a lot of nasty substances called cytokines, which do a good job of killing the infected cells, but they make you feel like crap. And eventually you get better, and the immune cells will disappear because there's a yin. They multiply like crazy, and then they kind of fall off and they go away, so you don't need them once the infection's cleared. Somewhat similar thing can and should happen in the cancer setting, and getting that to happen is not so easy. Because in the cancer setting, what happens is the cancer cell is very diabolical. It takes advantage of all the negative regulators of the immune system, which we normally need, but it overexpresses them. So for example, here is a situation where you have an immune cell, the yellow cell is the immune cell, and here's the target. If on the immune cell you have something called the T cell receptor, that's what recognizes the bad guy. That's great, but there are brakes in the immune system. There are brakes and accelerators. What happens is in the cancer state, you have too much brake. CTLA-4 is a brake. And the immune cell, instead of killing the tumor target, makes a lot of a substance called CTLA-4, which acts as a brake. It doesn't really work. And what we try to do is if you would make an antibody, and that's what this little Y-shaped thing is, to block the brake, it would allow the immune system to work in an unfettered manner. So once again, we have all these substances that act as brakes, and we have all these things on the immune cells that act as accelerators. The problem is there's too much brake and not enough accelerator. Anyone ever tried to drive a car with the parking brake engaged? I don't know if you have, but I have. Usually a rental car, it's unfamiliar. You get in the car, you start the car, you press the accelerator, and it kind of drives, but it's sluggish. Then you look down and say, oh my God, the parking brake's engaged. Whoosh. Undo the parking brake, boom, fine, everything now moves terrifically. Well, the immune system in the cancer-bearing state is like you driving the car with the parking brake engaged. It sort of works, but it doesn't work very well. Using this antibody to unblock the immune system is like you getting, I don't know, some shears and cutting the cables of the parking brake and disconnecting one of the two redundant normal braking systems, right? Because in cars today, they're redundant regular braking systems, which means your car is going to drive really well. The problem is stopping the car is not going to be so easy. So that's what happens. And this CTLA-4 was a brake. It became evident in the 1990s. That's the way it was. And there were a couple of scientists who made this discovery, one of whom is a guy named Jim Allison, who will probably get a Nobel Prize for this eventually. He's already won the Lasker Award, which is the precursor to the Nobel. And again, what happens is the immune cell gets activated, and in the normal setting, you have the yin, you have the immune system activated, but eventually it does its job and you have to shut it off, right? Or else you die of overimmune stimulation. So what happens is there's too much CTLA-4 in the tumor-bearing state, and we need to figure out a way to shut it off. So blocking it seems like it would benefit immune response against cancer. And an antibody was created, and it was first developed in 2001. And at first, everybody was skeptical. Yeah, it was another boondoggle immune therapy for cancer that wasn't going to work. But when I was in Los Angeles at the time, one of the first patients, I think it's the end of 2001, maybe beginning of 2002, when this drug was first in humans, we had one of the first trials at USC. And I saw a patient who was a cardiologist with severe back pain, and he had a gigantic mass. I mean, you could feel this thing. It was projecting out of his back. And it turned out it was originating in his lung, in his pleura, and extended all the way through his chest wall to his back. It could not be removed surgically. It was just too big. And he had chemotherapy. He had interleukin-2, which in those days were the only treatments that really did anything. And he then came to see me. And after 2 treatments with this antibody, which we now had a name, it was called Ipilimumab, he stopped needing his pain medicines. And I saw him for the 3rd dose, and I was very impressed. And I said, I'll be damned, you know, it looks like your mass used to be like this, and now it's like that. And I said, maybe it's doing some good. Well, after 12 weeks, the mass completely disappeared. He didn't need his pain medicines anymore, and he said he wanted to go back to work as a cardiologist. And I was quite impressed. And then we scanned him, and the mass was gone. And by the way, this is like 2002 today. I get a postcard from him every once in a while. He's now retired. He's in his early 70s, I'd say, and he's fine. So he was cured. And after seeing that, I became a believer, and he was like the first of a handful of patients that we treated on an early phase trial. So I was quite impressed. And after this, I became a believer that the immune system could indeed be manipulated to help these patients. And the proof of the pudding was in the original phase 3 randomized trial, which means a phase 3 trial is when you go head-to-head with your treatment versus the established treatment. And this was a trial in patients who had failed all other therapy for melanoma, so there was no established treatment. So the control, which is in yellow, which looks terrible, right? Because this is the survival curve. And over time, almost everybody dies. There are fewer than 10% patients alive at 3 years. But if you get one of 2 regimens of this new antibody, this Ipilimumab, which unblocks the immune system, it's pretty obvious they did better, because on the y-axis here is the number of patients alive, and this is time. So over time, this plateaus out so that by 3 years, so go out to 3 years here, that's where the green dot is, you have just about as many patients alive at 3 years as you do at 5 years, as you do at 7 years. So this is a survival plateau, which would mean if you had no treatment, the plateau would have been down here, where the arrow is. Can you see the arrow? Yeah. Now it's up here, it's about 20%. So that meant we had increased our cures by at least 10%. Now that means you have to treat 10 patients to cure 1 patient. That's kind of an expensive proposition in terms of side effects and money. But still, this was an advance. We had never been able to do this before. And now, for the first time, we were able to talk to our patients about the C word. We were actually able to talk about curing them. And we also realized not only could you cure patients, but there were some weird responses. Usually with chemotherapy, what you see is what you get. Yeah, with chemotherapy, by the 6th or the 8th week, the patients either going to shrink or they're not going to shrink. But with this treatment, sometimes the tumors would grow and then they would later shrink, which is bizarre. Sometimes new tumors would pop up, then the new tumors would go away, then the rest of the tumors would shrink away. And this was bizarre and unique, and it was only with immunologic therapy that we would see this. It sure as hell doesn't happen with chemo, and the typical thing is this, and anybody can figure this one out. It's a famous case. This is the liver on a CAT scan. Liver has some teeny little dots at the beginning of a treatment. And this was from a colleague at Memorial, Jed Walchuk. After 12 weeks, you see all those black or dark gray dots, those are all tumors. Obviously, that's bad. The patient was progressing, the liver function, blood tests were abnormal, they felt terrible, it was just not good. So my colleague decided to wait and see if they could get the patients on a new trial, and they had to wait a long time. He had to wait 8 weeks. At about the 8th week from the evaluation, which is now week 20, they brought the patient back, and they looked at him and said, boy, the guy looks good. And his liver functions were better, and he just felt better. And then they said, well, we have to get a scan in preparation for your new trial. So they scanned him, and look what happened. All the big black dots are now little black dots. They said, whoa. And he had not had any therapy in the interim. So they said, whoa, time out. We're not going to do anything. We're going to see whether you continue to respond. And they were able to give him another dose of the Ipilimumab, and then continued to get CAT scans. And if you look at CAT scans now, 4 months later, tumor is almost totally gone. And actually, this guy lived for years. His tumors essentially completely went away, and he had what we call a complete response. That is not stuff you ever see with chemotherapy. So there was something weird about this. And we also realized that there were these weird, crazy side effects, because the drug not only could make the immune system get turned on, it not only could make tumors go away, but it also inflamed specific organs of the body. And we saw crazy, weird stuff that we had never seen in the state of nature, things that I had never seen before, inflammation of the colon, bizarre rashes that looked like, in one woman, she had a rash only on the left breast. and it was this incredibly thick, dense rash, and I was convinced that I had caused her to have something called inflammatory breast cancer. And we biopsied it, and the pathologist said, there's no cancer there. It's just a lot of immune cells. And this is back in, it's probably 2002. And it just hung in there and didn't go away for many months, and it eventually went away, and her tumors eventually went away too. Hepatitis, swelling of the lymph nodes, crazy stuff that we had never seen, and inflammation of the pituitary. Pituitary is a little gland up there in the base of the brain that controls your hormones. And if you look at the yellow arrow on the left, pituitary is this little teeny thing. It's literally the size of my pinky nail. And it normally does an important task. It regulates your hormones from the thyroid and the testes in men and the ovaries in women. But here's a patient who got treated with this drug, and after a number of doses of the drug, had the worst headache of his life, and they did a scan of his brain, and he had a little bit of swelling of the pituitary. But if you look at the difference between this and this, it's not that much. But that little difference made this person have the worst headache of their life. We also saw loss of pigment, vitiligo, and that vitiligo was associated with doing well. So here's a guy who's lost pigment. If you see here, his pigment is going away on his face. On the arms, the pigment's going away. And bizarrely enough, it turns out the loss of pigment was great because almost everybody who had loss of pigment did well in the long term. So we saw crazy side effects, we saw crazy responses, but the good news is in a significant number of patients it actually worked, and they maybe could be cured. And it wasn't the only type of immunotherapy, because then came along another antibody against another substance called PD-1. So PD-1 is yet another brake. It turns out it's probably a more potent brake than the CTLA-4 on the immune cells. So interestingly, it has fewer side effects than the CTLA-4 antibody. And it's more like a sniper rifle, very directed, rather than a shotgun, which is the way CTLA-4 is. And again, if you look at the immune cell, it has this thing on it called PD-1. It also has the CTLA-4. But on the tumor cell can learn how to increase a substance called PD-L1 in blue, which binds the PD-1 on the immune cell in orange. And when that happens, it shuts down the T cell. Think about how diabolical that is. The tumor cell has within it the capacity to shut off the immune response. So if you had an antibody that would block this interaction between the orange and the blue, again, it's like cutting the brake cable. It allows the tumor cell to work better. And it works. Here's a similar survival curve. And again, notice once you get out to 3-4 years, there's a plateau. And the plateau is outlined in the box. It would suggest that now it's not 20%, it's like 35%. So we've gone from 10% survival at 5 years with lousy treatment, 20% with this CTLA-4. Now we're at 35%. And these were patients who were bad actors. That means they had failed all other therapy. It suggests that maybe we're going to do an even better job of curing them. And when it's used in what we call the front line, meaning patients who had never had prior therapy, this is the survival. Look how good this is. Now, you're only out at a year, but this is the 50% line. And in this trial, this red line continues to come down, but it plateaus at about 40%. So now we're doing even better. And this is what happens when you get chemotherapy. This stinks. Almost all these patients are eventually going to die. So it beats the heck out of chemotherapy. It was approved by the FDA 2.5 years ago. In fact, it's one of 2 antibodies against this thing called PD-1, this other brake, that have been approved in melanoma. So conclusion for PD-1, it is an outstanding antibody. It doesn't have too many side effects. It's got fewer side effects than that Ipilimumab. And the response rate's pretty high. It can get up as high as 45%. And if you respond, it lasts a long time. And then the question was, what if you combined it with the CTLA-4 antibody? So the last couple of slides show that when you give these 2 things together, now you're out at 2 years. Look where you are now. I told you you went from 20% to maybe 40%. At 2 years, now you're at 60% or more. And this is pretty good. So this is what happens if you just get that Ipilimumab, the CTLA-4 antibody. This is when you combine it with the PD-1 antibody. And this is the survival. And it looks like you're doing better still. And if you look at giving them sequentially, you still do better. This is when you give the PD-1 antibody, then you give the Ipilimumab, and then you give more PD-1 antibody. This is up in the 60% range at 2 years. That says you're doing pretty darn well. So successively over time, we started with one antibody, went to a second antibody, and then we gave them both together. We keep on doing better and better and better. So conclusions of all this about immunotherapy and melanoma, we call this checkpoint inhibition because each of these things is a checkpoint. It's like a brake. It stops the immune system. So the treatment is checkpoint inhibition. It has changed the face of cancer therapy because it's not just melanoma. We have now had multiple drugs approved in melanoma, but these same drugs are approved in head and neck cancer, kidney cancer, lung cancer, Hodgkin's lymphoma, you name it. It's going to be approved in 10 cancers in the next couple of years. It's modestly toxic. There are side effects, but it can cause shrinkage of long duration and maybe cure some patients. It turns out there are dozens of these checkpoints, so you can make antibodies against maybe a dozen different molecules that might benefit patients. The presence of this thing called PD-L1, which binds the brake, and it helps to engage the brake on the tumor, as well as the presence of the immune cells in the tumor, are markers for its effectiveness. And interestingly, it turns out that the number of mutations in the tumor, which you would think would be bad, is actually good because it makes targets for the immune cells to hit. And there are literally over 100 trials of combination immunotherapy going on. Where this is going to end, we don't know, but as I usually tell people, the best is yet to come. So I think I'll give way to the next speaker, and thank you.